Heading into 2026, Nigeria's health story is one of cautious optimism.
According to numbers, the intent is unmistakable. A proposed 2.48 trillion naira allocation to health, ranking fourth on the government's priority list.
42.18 billion naira aimed at providing basic health care to 10 million of our most vulnerable citizens.
The figures clearly signal a commitment, though turning these plans into real healthcare remains the challenge. Everyone is watching closely.
Really, and that's true, and that's right, Yenre. That cautious optimism comes straight from experience. Last year, outbreaks of Lassa fever, measles, and cholera put the country's surveillance systems to the test.
The temporary freeze in U.S. foreign aid also impacted HIV programs, highlighting how reliant the sector is on donor support.
And the health workforce shortages, they became impossible to ignore. Yet, there were bright spots, new oncology centers.
Yes, of course. And there was a nationwide vaccination drive, insurance reforms, and efforts to strengthen primary healthcare delivery.
And that's the bigger picture. The 2026 Health Sector Joint Annual Review in Abuja wasn't just a formality. It was a moment of reckoning. Nearly 1,000 health practitioners examined what works, what doesn't, and what must change.
Indeed. Talking about the review, that's for last year, right? 2025, fantastic, update from the key figures in the health ministry. And of course, universal health coverage was also renewed last year. If you paid attention to the news, digital tools were showcased and digital conversations about corruption and financial risk were finally, brought to the open.
Now, as lawmakers debate the 2026 budget, the question Nigerians are asking is simple. Will this allocation mean medicine on shelves, health workers at their post, and care reaching people before crisis hit?
And maybe we should emphasize the medicines on shelf should be valid, or if you like, potent, affordable medicines, of course. Now, our spotlight is on the country's health sector today and what outcomes to expect this year. Welcome to Good Morning Nigeria. I'm Henry John.
And I'm Ademola Adeoye. Welcome. I welcome you as well. This is Good Morning Nigeria on the network service of the NTA.
You're still watching Good Morning Nigeria live on the network service of the NTA, and we're discussing health outlook for 2026. And before we bring in our guests who are already seated with us, let's quickly take a look at this background report put together by Ibrahim Bello Gunda.
The year 2025 was a defining one for Nigeria's health sector. The year opened with heightened disease surveillance, as the Nigerian Center for Disease Control and Prevention reported outbreak of Lassa fever, measles, cholera, and mpox, among others. The year saw Nigeria continue to grapple with a severe brain drain as thousands of health professionals migrated abroad, while industrial action further strained the system as the Nigerian Association of Resident Doctors, the Joint Health Sector Union, and the Assembly of Healthcare Professional Associations also partake in strikes over various demands, thereby paralyzing many tertiary and general hospitals. President Bola Tinubu launched the National Health Fellows Program to improve service delivery and accountability in primary healthcare centers. The federal government also inaugurated 3 state-of-the-art oncology centers in Katsina, Enugu, and Edo states to boost cancer care. The government also launched an integrated vaccination campaign targeting measles, HPV, polio, routine immunization, and neglected tropical diseases nationwide. The National Health Insurance Authority intensified effort to expand insurance coverage to reduce out-of-pocket spending. The 2026 budget for healthcare sector saw a significant allocation of 42.18 billion naira to provide basic healthcare services to vulnerable Nigerians, which is part of the 2.84 trillion naira allocated to the healthcare sector, representing approximately 5.18% of the federal expenditure. The healthcare sector budget is expected to support a wide range of interventions, including disease prevention and control, healthcare service delivery, medical supplies, and targeted programs for vulnerable groups. During the budget presentation, President Tinubu emphasized the role of healthcare in driving sustainable national development. How did the country's healthcare sector perform in 2025? How will this impact the prospect in 2026? And what should be the priority of the sector this year, considering challenges and gains recorded? These and more are some of the questions Guest and Good Morning Nigeria will find answers to as we discuss the country's health outlook in 2026.
Thank you very much, Ibrahim, for that background report and for those questions which I'm sure that our guests will be able to prefer answers to them. We already have our guest seated in the studio, and just let me start by introducing Dr. Ainomui. He's the Executive Director, National Primary Health Care Delivery Agency. Dr. Mui, it's good to have you join us, and compliment of the season. Happy New Year to you.
Thank you very much. It's always a pleasure to be here. Good morning.
All right.
All right. Also joining us for the conversation right here in the studio is Professor Titus Sunday Ibekwe. He's an otorhinolaryngologist and health policy and management expert. Quite a long list. We're talking about his achievement. Provost, College of Health Sciences, University of Abuja, Secretary General Association of Provosts of Colleges of Medicine in Nigeria, immediate past chair, American Academy of Otorhinolaryngologists, and head and neck surgery. Like I said, it's a long list. And past National Affairs Vice President, Nigerian Medical Association. It's indeed a pleasure to have you with us, Prof. Welcome.
Thank you very much. Happy New Year.
All right. Thank you so much, gentlemen, for coming. We're talking about the health sector, which we know that is one of the major essential sectors in Nigeria's. Just recently, I mean, even last week, we talked about the challenges facing the health sector, especially when it comes to logistics and human and other things like that. But let's look at the challenges that in the primary health care now, Dr. Mui, in 2025. What prospect do you think, how do you think it will impact this new year?
Thank you very much. I think just a little bit of context is that we're now 2 years and a little bit in government. I think when we came in, we took stock and recognized that we, in fact, were starting from a very low base. I think it'll be not accurate to not recognize the fact that if you look across the network of primary healthcare centers, the quality of infrastructure, the presence, adequacy, and attitude and knowledge of the health workers was far from what it needed to be. But we got to work. You know, we did some planning, some prioritization. So the first year, which was really most of 2024, we spent a great deal of the time mobilizing resources and trying to figure out how to optimize services when you don't have enough to go everywhere. Okay. How do you expand gradually to make sure that at any point in time you're getting the best value from the investments that you are making. The second year of full year that we did was 2025, and during that year we saw remarkable progress in a lot of the priorities that we had set. For primary healthcare revitalization, for example, we added 2,360 thereabout, a little bit more, facilities that are now level 2, meaning they have all of the complements of inputs needed to provide basic services for Nigerians, offer 24-hour services, have backup power, have the workforce, have the supplies and things like that. And there's another 1,600 or so that, are in process. We're doing this not just as the federal government, but as the federal government. A lot of that is also being done by the states, in fact, through resources that are jointly mobilized. And even the private sector, is contributing to that. For workforce as well, we focused on two things. One of them is to retrain the people that are there. So the president set a target of 120,000, for over 4 years. We're now at over 78,000 that have been retrained in integrated primary health care services. What that means is they have more up-to-date knowledge, including their attitude and how to treat patients today, versus how they might have approached patients in the past. We are also on a recruitment drive.
Okay.
The responsibility for hiring is with the subnationals primarily, because they own the delivery and operations of primary health care. We just facilitate and enable them.
And what has been their response to that?
There has been, it's encouraging. It's not nearly what it needs to be, but I think there's reason to believe that the engagement is a lot more. We've had, between community-based health workers and skilled birth attendants in the facilities, if I look at just 5 states last year, there were at least 3,000, 3,200 thereabouts. New health workers that were recruited, for primary health care centers. I'm sure tertiary facilities also employed a lot more. In fact, I know that some secondary facilities probably recruited. So there is some progress there. And we started to see that in the service utilization at that level. If you look at antenatal care, for example, if you take the third quarter of 2023 and compare to the third quarter of 2024, there's a 31% increase in terms of just service utilization in the facilities. So this is the number of service delivery units, if you can call it that. Not necessarily individual people, because sometimes people go more than once to the facility. But that's to tell you that the trust and belief is starting to rise. But you see, to your second part of your point around what does this mean for 2026, we think this is the year where we do a number of things. One is to consolidate on the direction that we have now established on many of these programs, right? This is the year where you want to go to scale very quickly. Of course, we have now shown what needs to be done where. This is the time to bring in non-state actors. We have over 30,000 primary health centers across the country. Even if the government was to continue investing, you can't get to every one of them. You can't touch everyone in the time that we need, because everybody has limited time, in this position. So one of the things we are going to be doing a lot of this year is really rallying the troops in the private sector. Imagine if every 1 in 2 or 1 in 3 churches were to adopt a primary health center in this country, for example, and just contribute their time in terms of volunteerism, contribute a little bit of investment, and just participate, check to make sure the health workers are doing what they're doing. The money, the direct facility finance and basic health care provision fund that government is sending is being utilized well. So when you participate in your own primary health care service delivery, it's not necessarily just that.
How do you intend to achieve that? I mean, getting people at the local level, to participate?
I think it's a number of things. The first thing you need to do is try to come through on what you said you will do. And I think there's a little bit of that now. When you make a promise, when you do it, then people start to pay attention to you a bit more. And so if you look at the promises we made around primary health care revitalization, the journey has started. I think many Nigerians, if you look at the sentiments, there's still a lot of gaps, but people are now recognizing the progress that we are making there. That's the first thing. So people they feel more able to invest their own time and resources with the trust that they can see where it will go. That's the first thing. The second thing is that, we're also embarking on a stronger awareness drive. Over decades, people have disengaged because the system has let them down. But what we are seeing now, frankly, is that there's a lot more engagement and discussion, around the health sector. A lot of the discussion is still around the gaps, and that's what you expect, because there are still gaps. But at least people are now interested, people are now engaged. And when that happens, what you then have is an opportunity to show people their own role and how they can participate. I think the world is also changing. So the era where you have a headache, you have a health scare, you get on a plane and go somewhere, to get that checked, I think it's starting to go down for a number of reasons. There's just a relative cost given the currency exchange, but also just the world is not as welcoming as it was, across board, and that's more geopolitics. So I think more and more we're having to look inwards. People are having to take ownership, and as we have engaged with the communities, you can see the impact. So in the introduction, there was comment around the measles rubella integrated campaign that we did with polio. We targeted about 60 million children in the first cluster of northern states. We got to about almost 95, 96%, 59.6 or 7 million, thereabouts, and that is a lot better. This is verified information. That's not, that's accurate. And that's a lot better than even we thought we really would achieve. But that's because now, yes, we got the communities to really own that.
Besides the fact that, because most times the health centers are usually referral centers. The direction that you want to, told this year, will it be to deliver more services besides being a referral centers?
It's a number of dimensions that we want to focus this year. I think we're going to continue the drive to just increase the quality of the facilities. The primary health centers are not necessarily referral centers. They are usually the first point of entry. And then we refer to secondary and specialist hospitals, like where the professor works now. But as we continue that, we continue health workforce, we continue that, we also want to focus on quality of service delivery. Okay. So it's one thing for people to be coming to receive services. It's another thing for us to focus on making sure that when they come, they do receive the right quality of care that they should get, in terms of that they getting the right diagnosis, are they getting the right treatment, are they getting the right follow-up, even education and counseling. And are we measuring that so that where there are gaps, we also are very clear what we need to do. So we will see a lot of discussion and push at the primary healthcare center level on quality. In fact, we were just in conversation with the DG of Nigeria, National Health Insurance Authority yesterday, where they are leading and we're supporting them through an accreditation process of the primary health centers. Okay. So if you don't meet certain quality criteria, you're not going to get the basic healthcare provision funds that the government is giving. So that's an incentive for you to make sure you have the environment, you have the health workers, you have the commodities in place, and when patients come, they receive the services, and if they're covered by insurance, they don't have to pay for anything out of pocket, So those are the sort of things that we will be focusing on.
All right, many thanks, Dr. Muyi, for your opening comments. I'd allow you to take a breather. Initially, I intended to ask you a question, but I think I would just get to Professor Ibekwe now. Listening to Dr. Muyi talk about the intervention so far in the primary healthcare sector, you would expect that, a lot of things would have changed. Talking about things that have changed, of course, there are reports that antenatal care, skilled birth attendants, all of that has improved. But yet, under 5 mortality rates remains high, neonatal mortality rates remains high, maternal mortality remains high. Speak to us, despite these interventions, why do we still have these scary figures in this sector?
Yeah, thank you very much. Well, the intro you did earlier on, I think, has said it all. It has summarized what is going on currently in the healthcare system of Nigeria. It means that we still have a lot of gaps to cover. There has been some improvement in some areas, clearly, but if you look at the areas of deficit, we have not gotten there yet, because healthcare is a comparative system, it's a comparative analysis. And there's always a reference point that you're going to, a minimum that you expect in order to have a serviceable healthcare system. If you don't get to those required metrics, standards, as rolled out by WHO and others, then that means we're still trailing behind. And it is the reality. Kudos be given to the system. There have been areas of improvement, as pointed out. You talk of areas of immunization. We've done excellently well there, because HPV coverage and co now, you're talking of up to 98%, which is really, really amazing. Because trying to prevent infection and ephemeris from happening itself is a big deal that will save you a lot of cost and resources. But when you look at the healthcare financing system, which is like, the nucleus, if it is well executed, that will drive any good policy that you have on ground, we have not really fared well comparatively. You can look at the figure, they look big, 2.48 trillion. But the reality is, when you juxtapose this to the percentage of the total budget of the country, we're talking of just a little bit above 5% and fractions. Whereas expectations in a treaty that was signed here in Nigeria, in Abuja, that is called the Abuja Declaration, we expect minimum of 15%, of the health care system budget to be dedicated to health, for you to be able to get a very serviceable healthcare system. So you can see the gap is much. Now you look at the implementation of the Nigeria Health Act, which everybody felt is like the tonic in 2014 when it was passed. Because everything that you need, every metric that you need to really, take our healthcare system to that desired level is embedded in there. It is a holistic document following a lot of pressure. So if you look at that, implementation is still a far cry, within. And the basic healthcare fund, which again is the soul of that document, the implementation is something else that we have to look very, very closely at. And that is what is affecting healthcare delivery system, both in private setting and you talk of even the public health centers, because they are supposed to be like a clearinghouse. Whenever you give emergency healthcare services to those that really need that without payment, you just make your clear documentations and get refunded afterwards. But whereas this is not working, you agree with me that those, especially those in the private setting, if they continue this way, they will easily fizzle out of the system. So these are areas that are very important that we have to look at.
So, Professor McQuarrie, you talk about, the budget not being enough. We were still scratching 5% instead of 15%. But talk about the 5% that, has been, budgeted, in the last how many years. Has there been transparency and accountability in this sector such that we can actually touch tangible results, or if you like, feel results from the impact of what has been budgeted so far?
A very sensitive question you have asked, but I would say that in the public domain there, I think the answers are all there, glaring at us. A good number of times, the near envelope system that we operate in the budget, you have a lot of deficit of the budget not being accomplished before we roll over to the next year. So it doesn't help the implementers and people who are all out, brace out to even utilize the little that has been budgeted. So whereas out of the 5%, at best, 50 or 60% of it is only what is released before the year is over. You will see that those healthcare planners will find it very difficult to be able even to execute within the little limit that has been given. A rider to this, which is also very similar, is when you talk of the insurance system. Because these three, they must go together. Out-of-pocket expenditure is not fashionable anywhere. It's not sustainable anywhere. All right? So a robust insurance system will be like a shock that will help to boost, the little budget that you have put into the system. And in 2022, that act was modified. That makes it National Health Insurance Act, right? So it was modified now that every Nigerian has the right to be covered within the system, within that inventory of the insurance system. But today, there has been some relative improvement because we have to give it to the system where we have done well. Okay. But that relative improvement has just been from like 6% to about 10.1%. But is that what is desired? I recall that about 4 years ago when we were having similar discourse, in your studio here, Ghana was celebrating about 60% coverage of their own health insurance system. I don't know where they are right now. So we're still far away from that desired, goal, despite the, incremental improvement that has been made. But it's not enough, to bring out that essence that you really need to see, and that the citizenry will really enjoy the healthcare system. And the health workforce, or the workforce itself, retention is very important. You know, Dr. Muyi rolled out a very important program that I've done, which is very applaudable in trying to retrain. But whereas you complete this retraining, there has to be effort at also retaining them within the system. Otherwise, you retrain for others to be poached at pittance. You know, as I said, healthcare delivery is a comparative analysis. You must look at what is happening in your region. I give an instance. Within our region, and it is verifiable, in a place like Togo, the lowest paid professional, the healthcare professional, like a consultant, goes home with about $4,000 equivalent of the salary. And I'm very happy one of our ministers, when we were discussing, said that that's why he's looking inwards to see what he can do. So you can see around you if the performance is so poor. You finish training, it will just be like a drain pipe. And the Nigerian healthcare workers are among the best all over the whole world. That's why they're highly sourced for. You go to any renowned, you know, healthcare delivery center across the world, they're out there doing marvelous job. And they are willing to stay back. That is why you look into what is happening today. You start talking of industrial action every now and then.
Besides
paralysis within the hospital.
Besides the issue of remuneration, what about the issue of probably facilities? Do you have adequate facilities?
All these things, they go together. All right. So when you have proper facilities, then you have good remuneration. Those are those attractions that will retain your workers, because every healthcare worker wants to enjoy the work he's doing, want to, you know, at ease deliver what you're trained for.
Fulfillment.
Yes. So the facilities, they are not where they're supposed to be. We still have a lot of gaps. But that is where some of the policies that government is putting forward is excellent. For me, public-private partnership is an excellent one. Government alone cannot do it. They should bring in the right people who really have good intentions and not to milk the system dry. Good intentions of investing, you know, to the system, and be patient enough, because these gains, they percolate over time. You can't just recruit or recoup your investment overnight.
Okay. Thank you, Professor Bekwe. Thank you so much. Let's get back to Dr. Muyi. I mean, you've mentioned, you know, he has mentioned a lot of gaps, really, and these gaps have existed, you know, for a very long time. Some say the gaps are getting wider, and some say the health sector is sick in itself. So, but you know, speak to us really. When you spoke, you know, a while ago, you talked about the fact that recruitment of staff in the primary healthcare centers is with the subnationals. Speak to us about what your agency is doing to ensure that these subnationals do the needful in that regard. Because, I mean, there's stories every day or everywhere about, you know, primary health centers well built, but there are no professionals there to work. Or if you like, you have quacks, or if you like, underskilled, you know, people in such facilities, which of course is causing a lot of death and chaos in the health system. So what are you doing to hold these subnationals accountable?
Yes, so there are a number of reasons why, when you talk specifically about staffing, where those gaps have existed in a chronic way over time. One of them is what Professor Bekwe said, which is, you know, over decades, the primary healthcare system and the health sector generally has struggled to hold on to healthcare professionals for a variety of reasons. I think you said some of them, but when you look at them from a policy perspective, you also have to understand that you're working within a framework, within a system. And the way the government of President Bola Ahmed Tinubu and Minister Pate are pushing very hard to try to address those things and solve the issues of salary and remuneration and other work environment issues. You've talked about, you know, the investment in tertiary facilities so that the ability to actually practice like your peers would practice in other places, that's a motivation. But also things around you know, accommodation, you know, especially in rural areas, and some of the other attractions that help people to stay. Those are ongoing, that we're investing at many different levels. Okay. But that loss to emigration, to out-migration, you know, is one. The other bit of it, why it's been like that, is, frankly, historically, the investment, the construction of primary health centers has not always been done in the most strategic way, where even the number of facilities itself does not match either the need or the resources that you have to sustain them. When you don't have enough health workers for one facility, it's not very intelligent to build another one right next door because there's a new political leader in office or because there's somebody who doesn't like whoever was invested in the first one. We've had a lot of that. So the first thing that we did, because the National Primary Healthcare Development Agency has a responsibility for the development of primary health care, which is coordinating what the states do, guiding them, is to even do a mapping to say how many facilities are there, how many do we need, and how many can we prioritize to say if you have a minimum of this, that means this excellent criteria. And we did an assessment. We looked at over 28,000 PHCs across the country and decided that over the 4 years, we want to get to 17,600 high-quality PHCs. What that means is that, you know, in every geopolitical ward, you have at least one that meets level 2, and then in addition, we are doubling that number, so that about 8,809 thereabouts wards. Then we're having that equivalent number as well added that will be supported by Basic Healthcare Provision Fund, but those will not be 2 per ward, because some wards are larger in space. We did an analysis and it showed that if you look at whether you're looking at maternal mortality or infant mortality, what mattered a lot, what correlated a lot from a primary healthcare perspective is the distance between the high quality facilities. So when you are able to get to a facility, you can get the basic care that you need, but when it's too far and you can't get to it, then you are completely cut off. So in increasing the number of facilities, we solved for equity. You know, and right now we're at 13,500 that are basic healthcare provision supported, you know, and that's what we want to implement this year. I think we will add on to it as we go. So that's one of the things that we're doing, sort of planning and coordinating. But also, we mobilized some resources, government, domestic resources, and partner resources that we are giving to states through memoranda of understanding as an incentive for them to recruit. So, and there are multiple ones. Many have heard about the Project Hope, which is a World Bank financing thing where you get disbursement-linked indicators if you have health workers in X number of facilities, new ones, new health workers, if you have commodities and things like that. But even from my own budget of last year, from, you know, Federal Ministry of Health and other sources, we have resources that we're giving to states to say, you employ midwives, nurses, doctors. When you employ them, I will verify that they are newly employed, they are on your payroll, they are civil servants, then I will reimburse you the salary. Because the way we used to do it before, because of these gaps, my agency had 2,000 plus midwives hired and deployed across the country. We very quickly learned that I cannot sit in Abuja in my office and supervise health workers in 20, 30,000 facilities across the country. Many of them will abscond, you don't even know. It was difficult to manage the quality of care. So we said, let's do things the way the health system is designed to function. Let those who are close to the ground, who can manage them, hire them and supervise them. And we just have a mechanism to verify. And where we have resources as an intervention, you support them, you know, as an incentive for them to hire. And we're seeing response. And I think, like I said, we've also been fortunate. I think one of the things that the president has been able to do through many of his own interventions is to also inspire the state governors to be involved. It's not nearly enough, but I think we enjoy more than any time that I can recollect, and I've been around the health system for a while, you know, a level of interest from the subnational units that is unprecedented, frankly. You know, they want to engage, they want to invest. The financing, Professor, you also spoke about that, you know. We are in conversations. The states have expressed interest. They want to participate more substantially in Basic Healthcare Provision Fund. A lot of what is going out right now, it should be co-financed, but the federal government is who's paid the cash up front. There's efforts to increase what the federal government is given. There's legislation in the House now, you know, to double what the federal government is given as a proportion of consolidated revenue fund. But then we're also working with the Governors Forum to say how do the states substantively and the local governments, now that they are releasing more, they're getting more money from FAC allocations, fulfill their own end of it. Before I stop, there was also a question around the accountability for the resources. And one of the things that this government takes very seriously, is that every dollar, every naira that is spent in the health sector, that is public sector, we don't have as much control over what private businesses or individuals do with their sources, that you can trace it, you can account for it. A few months ago, many of you will have seen the red letter that my minister put out. And that really was to announce to Nigerians that we have now disbursed X amount. 32 billion, I think, was that particular quarterly disbursement of the Basic Healthcare Provision Fund. And you can see what goes to each state and calling on Nigerians to go to the facility. If you go to our website, Primary Healthcare MPHCDA website, you will see a dashboard there, a link to a dashboard where you can check all the basic healthcare provision facilities. Wherever you are, you can check the one that is near you. You can know whether it's receiving money. You can know how much it is receiving. You can go and check and ask questions, as an end user, as a citizen, as a community member. And we want to know. A few instances we have found, questions about what people are using. And so that's why sometimes, even when it's not everybody that automatically gets money now. You have to account for what you got the last time before you get the next one.
The reimbursement.
We work with the law enforcement agencies now. We have an MOU as a sector with ICPC, the Independent Corrupt Practices Commission, who also keep an eye on all of the investments that are going out there. Where there are gaps, we are trying to fix them. So there are a few things like that. For the first time ever, we are rolling out, we're now in 7 states, we're expanding to the rest of the states this year, a primary healthcare financial management app where it's an automated way you can see where facilities are spending money. And you can, when there are questions, you can track it. It used to be that everybody would just say, this is what I did with the money, this is what I did with it. Now, we're automating that so that you can
that's on the issue of accountability.
Yes.
Now, you've talked about the issue of accessibility, and also you talked about the quality of the personnel. That's when you talked about training and retraining of the health personnel. What about the issue of affordability? Because many of these health centers, when people go there, they ask them to pay and So what is government doing about that?
I think there are 2 components to that. The professor mentioned one, which is one of the ways that you provide financial protection for people to be able to afford healthcare is through health insurance. And if you look at the almost 20-year history of health insurance in Nigeria, we were at 6%, like he said. In 2 years, we've gone to 10%.
I'm talking about especially people in the rural areas now, because those ones don't even know about insurance. What's happening?
That's changing, actually. That's changing. That's changing a bit. There's a drive to bring in the informal sector. That's how you are going to get the 60-80% that he spoke about. The formal sector is the easy part, and that's what's been mostly captured right now. So we're expanding. The NHIA is driving very aggressively to expand to the informal sector. But beyond that, is the cost of commodities and the cost of medication. I think because of inflation and because of issues around importation, we saw an escalation, a couple of years ago in drug prices. And so the government, again, stepped on that frontally. The president, made some executive orders available for the health sector where we are driving very aggressively local production. Because when you have to import everything, then you are subject to the things that are not even within the control of your own country as a whole. It's a relative valuation of currencies in the world, global economic dynamics, trade issues, security concerns start to affect importation costs. And we saw a bit of that, in 2023 to early 2024. But then, through the president set up the President's Initiative for Value Chain in Healthcare,
Okay.
led by National Coordinator, Dr. Abdul Mukhtar, that has done an incredible amount of work in facilitating injection of investment into the country for domestic production of the medications that we need. And even for those ones that we cannot produce in the near term, because again, there's a wide array of medicines. Some of them are easier to make than others. Some of them are still patented. You know, there is now a pooled procurement mechanism that the Federal Ministry of Health has set up, where there's a group purchasing organization that will buy en masse so that you lower the cost. You also guarantee the quality, working with NAFDAC from quality assured manufacturers, domestic and international, so that the cost goes down. Beyond that, there's been a substantial amount of subsidies in terms of contribution of medicines from the federal government. In my agency alone, you know, about a few months ago, you know, we worked with the minister and pushed out commodities, maternal child health commodities, reproductive health commodities to every local government in Nigeria. Those are free, provided by the government, free, and the costs of those are not to be translated to the patients. We also do medical outreaches. Last year alone, I did 49, you know, because I had an intervention where you basically look at an underserved community where there's not a facility and set up shop for a few days and treat common ailments. Many of them do simple surgeries, cataract surgeries, herniorrhapies, cesarean sections. And all of that is really aimed to address some of the short-term acute stress that people are facing, while we solve through the value chain interventions, you know, in a more medium and longer term
framework. Thank you so much, Dr. Muyi. Do like our viewers to know that they can be part of this conversation by sending in their comments, questions, or if you like, recommendations. The number is on the screen, so you can send either SMS or WhatsApp messages. Thank you. So we hope to read them soon. I'd like to get to Professor Ibekwe. Of course, when you talk to people in government, they tell you, well, things are working, things are about to work, and all of that. I'm not referring to Dr. Muyi anyway. I'm just saying that's like a general whatever. But you are a professional, and then you get to interact with these professionals in the health sector. You already mentioned the strain that the professionals themselves go through in terms of remuneration, you know, facilities and all of that to work. But I'd like you to speak about Nigerians themselves when it comes to healthcare. We have a huge burden when it comes to cancer and some other diseases. You know, people, when you interact with medical experts, they tell you because Nigerians present late and all of that. So speak to us. Is it an issue of lack of education, or, if you like, not paying attention to health by Nigerians? Or is it the fact that we have a lot of quacks in the profession, such that there's misdiagnosis, you know, a number of times? And just recently, we heard the case of the writer, Chimamanda, who lost her son, you know, and the medical negligence is being blamed. We know that all of that has been investigated. But of course, stories like that continue to linger. What really are the issues, you know, when it comes to effective care? Because again, sometimes you access care, but it's not effective, or it doesn't lead to cure. So let's hear you.
Thank you. Well, I will start by sending my condolences to the Chimamanda's family for the loss. It's really a very painful one to each and every one of us. Anybody who is a parent knows how, you know, painful it is. Yeah. Mm-hmm. And anybody who is a health personnel also knows how it itches for you to lose any of your patients. The joy is that you derive from the healthcare services you deliver. You see your patients well and bouncing and coming back to say, thank you, doctor. It's not even the remuneration. Mm-hmm. And there's no healthcare personnel who knows this onions that goes all out there intentionally to go and perform malpractice in any way. It is not. But once in a while, some of these things can happen. Even in the best of hands, you know, there could be. So having said that, patient-centered care is what is being advocated worldwide. including those of us professionals here in Nigeria. The most important person in the healthcare value chain is the patient, because patient has to be satisfied. That's why even the treatment that you want to render to patient, you deserve the right to know everything that you want to do. And you have the consent of that patient, you tag on, you move along. It's like a contractual agreement. And your patient has a lot of confidence in you, like the doctor. Same with their spiritual leaders. So this set of people are special people who have, some good connections and with their patients. So you cannot assess the healthcare performance without getting the perspective of the patients. That's why patient satisfaction is very key. But having said that, whenever we are setting up some of these, metrics and setting up our system, the patient has to be taken squarely into consideration. Like the insurance, for instance, you made a very key point when you're chatting with me. We have a lot of people there in hard-to-reach areas that have not even heard of insurance. They don't know what it is all about. But of course, we know that there should be community health insurance system. And that has to do with education. So when you have people who will be able to assess and speak to these patients in language they understand, people who will be able to come down at their own level to explain to them what the insurance system is all about. They understand, they will key in. Because it's all about a pool where you make just minor contributions to secure your own healthcare system. You may not need it tomorrow, you may not need it next tomorrow, but your own relative may. So you're assured that whenever you get sick that you're covered within that system. So no matter how little they contribute, and those who are rich enough will come out with support to be able to cover such people. So it's very important. We don't have any reason whatsoever to say because we have had to reach areas and all those, that's why the insurance system should not get across. Then, the private sector, as I'm speaking to you, they're shouldering the responsibility for about 70% of the patient care in the country. It is also verifiable. Mind you that the Act is very clear that you have 3 tiers of healthcare system. The primary healthcare, which of course ministry is taking care of. You have the secondary tier of the system, which the state government is supposed to take care of. In fact, primary healthcare and the local governments are supposed to be the champions of this primary, healthcare system, which is like the fundamental, the basis upon which any successful healthcare system thrives. And above all, you can see that, I'll tell you that even some of the policies that we're generating is pro this system to thrive. Because today, local government, they have financial autonomy. If this is also truly implemented to letters so that what is due to the local governments get to them, they utilize it for their own people, you will see that primary health care will thrive and be able to permeate into this every fabric, every facet. So we are sure that those in the hinterlands are well covered. Secondary healthcare system and tertiary healthcare system are supposed to be a referral system. So those things that cannot be handled at primary healthcare system, you escalate it to secondary, which is the primary duties of our state governors and in fact the states generally. Then tertiary healthcare system is responsibility of the federal government, and quaternary healthcare, which should just be sparsely distributed here and there. So if we follow all these things down to letters, we won't have any problem. You talk of the Consolidated Revenue Fund, CRF. It is very clear in the section 81 of our Constitution what it's all about. So every earning of the government into one pool, at least 1% of it, has to be dedicated to this revenue fund. Now, be able to take care of emergency care system, be able to take care of infant, maternal, child health care system. We're able to take care of, immunization and vaccination and the lot. And when you're able to encapsulate and cover these areas, you see that you reduce infirmaries and healthcare burden of Nigerians to the lowest ebb.
Okay.
And of course, the private system, they need that confidence that when they actually treat and render these services, they will be paid as at when due. If the system of remuneration is dragging so much, it takes several months when they must have submitted their bills and all this before they're attended to. It drags the performance. It makes a lot of them to even not be very skeptical into working with the insurance system that we have.
Okay.
So we have to look inwards and keep on striving to improve on these areas that we still have snags here and there.
Okay.
In my book that I published 6 years ago, which I call Journey to the Golden Age, there is a tripod because it takes, different areas to work together to be able to succeed. There are tripods. The you talk of the security within the system. It's very important for health to succeed. There must be an assured security. For individuals to be able to come down here and invest, they must have their confidence that their investments are protected. They must have their confidence that their life is also protected. For the healthcare personnel to be able to come out at very odd hours in the day to attend to emergency healthcare, and even the individuals, people-centered care we're talking of, to be able to thrive and travel on time, because it's a timely thing to get to the closest center. Security must be assured. So you talk of health, which is the H there, is like in the center, and of course education.
Let's look at early detection
of these three.
Let's look at early detection of diseases now, where we are having disease outbreaks here and there, especially in your own area of specialization, that is ENT. How important is early detection in preventing serious illnesses and deaths?
Extremely important. I can tell you that it's the rate limiter to how your performance indicator, how you'll be able to come out at the end of the day, your endpoint. Because whereas you have the knowledge, whereas you have the facilities to adequately treat, and presentation is late, you do little or nothing. All your effort will be in futility. But early presentation will help you to be able to, obviate some of the complications that could arise from, such diseases, especially infections. We're talking of looking around today, there are some recurrent decimals. We keep on talking about Lassa fever, we keep on talking of cholera and all those. These are diseases of field, which speaks volume. And we need to do more. Those who are in charge of our environment, has to ensure that those basic amenities are provided. Portable water system, for the citizenry will crash and reduce the disease system to over 70%. I'm sure that Mo, you agree with me. Keeping the environment clean, and of course, a good health education that has to be very, very sustainable, unbreakable chain, that you keep on educating the populace every now and then so that they do the right thing. And doing that right thing also entails what you have asked, which is presenting early. Once you notice any change in your system, please, there's no room for trial and error.
Especially now that we have Harmattan, the atmosphere is polluted, is dusty, so what can be done?
Absolutely.
What should Nigerians do now, at least to protect themselves?
Well, you have to protect yourself. But as I said, you have to keep your environment very clean. You have to know your own health status. If you're an atopic patient, there are certain patients that are more predisposed to reacting to particulates within the air and the environment. Yeah. You go with your face mask. There is no shame in that.
Okay.
I use face mask myself. I have one here with me. You go with your face mask. You stay away from dusty areas and all those. Keep your environment clean. Ensure that your drinking water and all those are. If you are not sure of the source, please boil the water. After boiling, allow it to cool before you consume, So these are just some of the key things.
All right, many thanks, Professor.
Your food has to be well washed, The food and hand hygiene will have to, be on top of it at all the times. And this will help to reduce diseases and infection and transmission as much as possible.
All right, thank you. Thank you, Professor Ibekwe, for your intervention. Let's get back to Dr. Muyi now. We're about to take some of the comments. We have a lot of comments coming from our viewers. Just to let you know that you can also, send in your comments and questions. The number is on the screen. This is 2026. We may have challenges in the past, but of course we're looking forward to how, things can, become better. Speak to us about what your agency intends to do differently in 2026, really, so we can close some of these gaps.
I think 2026, like I mentioned earlier, for us is a year of consolidation and acceleration of the improvements in the infrastructure and the health workforce. But beyond that, I told you we've already started to see a trajectory in those inputs. We've started to see the right trajectory in service utilization. Now we want to focus on the quality of the services, whether it is maternal health care. Because it's one thing for you to go to the facility and receive care. It's another thing for that quality, for the quality of that care to be such that it's what you need and gets you the outcome that you merit. So there are many inputs, you know. We're focusing on the training, we're focusing on tracking and measurement, we're focusing on specific quality improvement interventions at the health facility level. I mentioned that we're revisiting the accreditation of the facilities so that you can't even, your ability to receive resources and even provide care is limited if you don't meet a certain bar of quality. So we're starting to hold ourselves and these facilities, you know, to that standard. We're also doubling down on certain areas of historical neglect. So we have a flagship program that we're implementing called the Maternal and Newborn Mortality Reduction Innovation Initiative, MAMI. And we have identified 172 local governments in the country, 33 states. People die everywhere, but these 172 local governments account for 55% of maternal deaths in Nigeria. It's a mix of population, deprivation, vulnerability, and other factors, other risk factors. So in those locations, we're specifically intervening. Again, in collaboration with the states, we're identifying referral sites. So and what we're doing is, who are all, for example, for maternal mortality, the idea is you don't want a woman to die because she's pregnant and she wants to have a baby, and that's preventable for the most part. So first of all, who are these women? Get a roster of them. Where are they in their pregnancy? And then support them to get the screening services that they need, the testing and diagnostic services that they need. When they need ultrasound, when they need urinalysis, when they need antenatal care, is to follow up with them to make sure they get it. If they are unable to get to the facility, take the services to them, or work with one of the other gateways of the Basic Healthcare Provision Fund, which is the emergency transportation system. We are also doing the emergency maternal, obstetric and newborn care as well, which basically says if you want to have a baby and you have a complication, you know, of course we will have screened you, we would have tried to identify, risk profile you. We want to make sure you get the emergency services that you need, whether it is emergency cesarean section, and many of you are aware of the free cesarean section that the government is doing now, so that when a woman needs to get emergency cesarean section and they cannot afford it, the government bears that.
In all of this, are you thinking about certifying some maternity centers? You know, besides primary health care, we know that in some rural areas in the hinterlands where primary health care centers do not exist, or if they exist, are not well funded. There are maternity homes, you know. Are you looking at certifying those homes that, you know, women patronize just so that...
If they meet the quality criteria. You see, the primary health care system has multiple tiers of facilities. You have health posts, you have the primary health centers, you have clinics and all of that. You also have maternity centers. Some of them are public sector, many of them are faith-based or other sources. We also work with them because the women go to them. So we make sure that they try to provide the right level of standard. But then they have to have the appropriately skilled workforce. That's important. That's very, very important.
Appropriate skilled workforce. Okay, we'll pause there. Yes. We'll pause there. So because we need to go on break now. So when we return, we'll talk about using digital tools to improve primary healthcare system in Nigeria. Stay with us. Thanks for staying with us. You're still on to Good Morning Nigeria on the network service of the NTA. And the discussion is still on the health outlook for 2026. Our guests are still here with us. And before we went on that short break, Dr. Muyi was going to tell us about, you know, what government is doing using digital tools to address challenges in the primary health care.
Thank you very much. What digitization does is it helps you in any system to improve your efficiency and your responsiveness, So we're deploying digital tools in multiple levels within the primary healthcare system. First, for service delivery itself, one of the things that we're really pushing at, and you will see a lot of that this year, is the digitization of our healthcare workers. So where they have digital tools that they're using to register and track individuals so that you can follow people up through the continuum of care, also linked to those facilities that are now equipped with the power and internet resourcing to be able to have their own EMR services, so that's linked. That's the first thing. That way you can also track your data. You can where you have a more sensitive system to detect outbreaks. So one of the things that we find is useful is that if you are digitizing your service delivery, if you typically will get 2 cases of measles per month, for example, once you start to have 4 or 5 per week, you can pick it much more quickly rather than if he has to go through a paper-based system, and then you can respond. So we're digitizing the service delivery using patient encounter digital platforms and decision support tools, because again, many of the health workers that are working in the front line, they're not doctors, they're not professors. So some of the things that they will see, they need tools to support them to make their decisions. So we're working with the Community Health Practitioners Registration Board, digitizing all of the standing orders, is what they call them, so that, it basically guides them through the care. Somebody coughs, this is what you do, this is what you ask, those kinds of things. I think there's that. There's also the training of our frontline health workers. So I told you that we're doing elite training in integrated care. And the way that has worked historically and up till last year is that you pull health workers into a classroom, some subset of them. They're there for a week, 2 weeks for these refresher courses. That does a number of things. There's huge costs and in fact risks from mass travel, for training. But we're saying there are not enough health workers in these facilities, yet we're pulling them, for these trainings. The one thing we did was to make it integrated. So it's not you go for HIV training today, malaria training next week, and that's what it was. But even at that, we're now digitizing the training. So we have now developed and are about to roll out. We now have about over 1,000, training video modules in 5 languages actually. English, Pidgin English, Yoruba, Igbo, Hausa, for community health workers, where we've worked with the training institutions and the licensing bodies to break the modules into bite size, where you can just go do a video on your own when you have 5 minutes or 6 minutes. You take a test, it tests your competency. If you don't know enough, you are made to repeat it, and we can track that, and that fits into your continuing professional examination.
All right.
Accountability for resources. Okay. I did say that we are deploying an app right now. 7 states already have it. We're expanding to the other states, where every PHC, the resources that is going to them, they are automatically, we can see what they're doing with it. So those are just some of the areas.
All right, great. Thank you so much, Dr. Muyi. Let's quickly read some of the comments that we have from our viewers now. This one is from Nandop. We have from Jos. It says, without strong primary health care system, without primary health care, systems become strained, leading to preventable deaths and disparities in care, hindering progress towards global health goals like the Sustainable Development Goals. Thank you for your service. Do have a very good morning, and God bless Nigeria. That's Nandom Weir from Jos. Another one says, good morning, Nigerians. Let's stop the Jaguar brain drain syndrome. Let's revamp our health sector. Health is wealth. That's from Chris Simon. And then says, good morning and Happy New Year. Today's discussion is quite interesting, and I've been following it carefully. May I humbly say that for Nigerians to access health delivery, government must do much to reduce the cost. Government health institutions are competing with private healthcare providers in terms of charges. That's from Edith Akman in Wuse to Abuja. Another one says, good morning. Thanks for your detailed insight, Dr. Muyi. I know you and your reputation, and as well as your passion to take primary healthcare to another level in Nigeria. But, sir, what efforts is NPHCDA under your leadership doing to see that qualitative and affordable medicine get to the rural hospitals? That's from Ibrahim Mouye. And finally, I want to sincerely appreciate the efforts of the health practitioners so far. But health practitioners should not be allowed to practice private hospital business alongside government employment. That's from James in Jos. That's saying that those health professionals that are government employees shouldn't do private practice, So I'm sure you want to respond before we read some more comments.
No, I think first just to thank the people that put in the comments. I think the number of kind words there, we appreciate it, and I think it's good to know that people are seeing, some of the effort that the president and his team, are putting into the primary healthcare system. So thank you for that. But, again, there are a couple of those things. One of them is, what is my agency doing to make sure that, yes, the cost of medicines is manageable? I think we spoke about it earlier, but you see, the cost of medicines doesn't even only just speak to the primary healthcare centers. In the teaching hospital, people have to even more advanced, more costly medicines. We know that the cost, has been quite a strain for many Nigerians, and there are many policy, programmatic, and in fact short-term palliative interventions that the government has done, is doing, not just the primary healthcare. From a policy perspective, it's executive orders from the presidential level that gives waivers and incentives for local production of many of the things that we are using. Of course, that started within the last 2 years. It always takes a while before you start to feel the impact. But the report that we have got from even customs services, anecdotally at the end of the year, last year, is that you can already see that in the importation volumes, but also in the rates, There's another element, which is that ultimately the pricing that you see in the market, there are many things that play into it. And while government tries to do itself to regulate, I think we Nigerians also need to regulate ourselves. Many times, even when there is a reduction in the cost, it doesn't always translate to a reduction in the retail price in the market. That's not something that is on government alone, because it's not government that is taking those margins. So I think there's a responsibility that we all have towards healthcare. Okay. There's also pooled procurement that is happening. I talked about the purchase, direct interventions, where we as NPHD, as Ministry of Health, were procuring medicines and giving to primary health centers, at least. Okay, Dr. Mui, yes. I just have to pause you there because some of these things you've talked about it earlier. Yes. So because of time, I still have some comments and questions here which Prof would respond to. This one says, I commend the federal government through the Federal Ministry of Health and the agency under the ministry, but healthcare delivery is suffering setback in our rural community due to the neglect from the subnational. Let them key into healthcare for rural community through primary healthcare community development agency. This one is for Yusuf Abdul Zaria. It's engaging at least one medical officer of health for each of the 774 local government is key to achieving success. Accountability remain a major factor in achieving success in ensuring that funds get to the desired beneficiaries. This is from Edwin Anthony from Makodi. It says, the Medical and Health Workers Union of Nigeria are always threatening strike, while government is threatening them with no work, no pay. Is there no other means of resolving disputes considering how important health is? Then this, the last one, from Dr. Sunday Lexum. He says, I commend the effort of the federal government in revitalization of some primary health care centers in Nigeria.
there is urgent need to mandate states in reforming their respective secondary health care, especially in recruitment of more personnel. I suggest that 20% of the budget should be allocated to health at the federal, state, and local councils. Prof.
Those were beautiful comments and beautiful suggestions too. I also subscribe to that.
Okay.
But let's even start by escalating it to just the 15% that we have signed in.
Okay.
And I'm sure that if we are able to show it up to 15% and ensure that it is truly implemented, it's not on paper, it goes to the right beneficiaries at the right time.
Okay.
You see a turnaround in the healthcare system. They want minimum of 1% because a lot of times that minimum is not cited.
Okay.
Because I was the national vice president of Nigerian Medical Association when that bargaining was done.
Okay.
The argument was that 1% was not enough. I'm happy that we mentioned that in the House now there's agitation towards increasing it. So ended up with minimum of 1%. But let's even ensure that that 1% is cut off from the CRF.
Okay.
And to get to the end users at the right time. You will see that when the quality of services, the quality of healthcare delivery, the deliverables get to the endpoints at the right time.
Okay.
You talk of both quantity and quality. The remuneration is fairly competitive enough, within the sub-region, just as I cited earlier on. Whereas a stone throw here, minimum that people receive about $4,000, whereas our highest professionals here, in the federal system is less than $1,000. So if these things are shored up a little bit, and all other efforts of the government is sustained, and we're looking worse to ensure that the budgetary system, accounting system, and all those, including even the digitization, because the digitization is like the spark. You cannot, operate a modern healthcare system, doing it how it was done centuries ago. It's still in the dark. You talk of, the record system keeping. You talk of ensuring that even the patient waiting time is reduced.
Yes.
You talk of research system, any area that you want to research on to find out how the key performance index is going. Within a twinkle of an eye, you get it ready and get it right. So all these things put together, we're now incorporating even AI in the servicing of healthcare system.
Okay.
But we're still talking of just digitizing to ensure that our data that are in fading out papers are in electronic system. That is what we're struggling to get right.
But what would be your recommendation in terms of education? Maybe what our universities or, if you like, health institutions should be doing. I'm asking that in the light of, like we already mentioned, reports of, professionals not doing the needful, or if you like, not skilled enough, to take care of patients. Would you want to see something being done differently, in that regard?
This thing I'll tell you is like, we'll call it a chain reaction, sort of. When the system at any particular time, at a point, like is a chain, a link, if there's a break in the chain or the link, then you don't expect performance at the other end. That's why everything that we've been discussing this morning is like the basis, the fundamental things to be gotten right first. Then you'll see, because years back, let's not forget that individuals come from even beyond Africa to come and procure healthcare system in Nigeria. Not to talk of now that the system keep on improving. When you talk of that quality and bite in the human resources is not lacking yet. Okay? But we need to make the environment conducive for that to be able to thrive. We need to ensure that the infrastructure that is needed, to be able to carry the capacity of learning, escalate it to that expected level, is on ground. And that is the good news regarding the putting pen to paper that happened between ASU and federal government. I hope it's something that, will be abided to, so that we'll ensure that our healthcare system, including the educational system, gets to that desired level. Because when there is, this distrust in the system, among those on the other side and the government divider, you say that we'll never get it right. Whereas that trust is there and everybody does what he or she is expected to do to ensure that the system moves forward.
Talking about trust, I hope we can begin to trust the primary healthcare center to deliver, because a lot of people have primary healthcare centers close to them, but they rather go to secondary or tertiary because they think that, oh, well, I may not get the best. So, projections, really, what should Nigerians expect?
I'll just say that.
In 1 minute, Dr. Mui, because of time.
In fact, that's a thrust, it's a key thrust in the strategy, is to guarantee every Nigerian access to basic health care that is high quality and from a system that they trust. And to be honest with you, for me, I think if you look at the trajectory of utilization, that's already a measure of the trust. You heard the comments from the people as well. So I think the trust is being rebuilt. There's still a trust deficit, and we're pushing it, but I think we're on the right track with that, to be honest.
Okay, you are building the trust now. The trust is being rebuilt. Okay, thank you very much, Dr. Mui. Prof, let's look, by the end of 2026, what clear changes should Nigeria expect to see in health care accessibility and quality?
Yes. The access to healthcare should be one that is easy and without bottlenecks to each and every one of us, even down to every facet and fabrics of Nigeria, including the hinterlands.
Thank you very much.
Very, very important.
Thank you. It's been a pleasure, listening to our guests this morning. We'd like to appreciate Dr. Aina Mui, Executive Director, National Primary Healthcare Development Agency. It was indeed a pleasure to have you. And of course, we look forward to having you very soon. So you tell us how far you've gone and, some of the changes that have been effected. It's a pleasure. Thank you.
Thank you.
Also, Professor Titus Sunday Bekwe, an otorhinolaryngologist. In case you're wondering what that is, it's an ENT specialist.
Well pronounced.
And health policy and management expert, Provost College of Health Sciences, University of Abuja, immediate past chair, American Academy of Otorhinolaryngology, head and neck surgery, and also past national first vice president of the Nigerian Medical Association. So many things, but because of time, we'll leave it at that. Thank you so much, Prof. And of course, looking forward to more conversations with you. All right, so that's our package this Friday. Thank God it's Friday. I'm Ian Ray John. Live it locked on the NTA.
And I'm Ademola Ade. Do enjoy your weekend. Thank you.